Okay, I think now that next year's president is in the room, we'll start the program. If you do have an empty chair next to you, please sort of look over toward the wall, and if you see people standing, sort of raise your hand and ask them to maybe move over by you. I know it's not a lot of fun to stand along the wall for over an hour. My name is Steve Edison. I'm with Encore. I'm also the chapter treasurer, and I've worked with George helping to put this program together, so thank you all for being here. It gives me great pleasure to introduce our next speaker. I've known Carolyn Byerly and worked with her for many years. She is currently the Chief Information Officer at Stanford up in Northern California. She has been there for the last 10 or so years. She has taken that organization from what I would refer to as almost the Stone Ages and turned them into a level 7, HIMSS level 7 hospital. And she's done an amazing transformation up there, and she'll share a lot of information with you during the course of her talk. In addition to her career at Stanford, she has also been involved with Loveless Clinic in New Mexico. She helped open the hospital and the clinic out in Mayo in the Phoenix, Scottsdale area. And then prior to that, she worked at a few organizations in the Bay Area, Good Sam in San Jose, as well as a children's hospital that's now part of CPMC, I guess, in San Francisco. So without further ado, I would like to ask Carolyn to come up here. Please welcome her. Thanks, Carolyn.
Thank you very much. Good morning. Wow, I am very honored to have been asked to come to this chapter. Steve and George have reached out a couple times, and I wasn't able to fit it into my calendar. But this year, they called early enough, I think, and I made an effort, and I'm happy to be here. I'm going to talk about a couple of things, and I pulled together slides from probably several presentations that I've made over the last couple years, in which some of the slides were used at board meetings and some slides used as leadership meetings. But I'm going to talk about a couple of things. First, I want to just share with you what Stanford's doing to deal with the current health reform and the challenges that we face in the next 5 years and how we're positioning Stanford. Second, I want to give you my take after doing much research like all of you to stay current in the industry and understand global changes that are coming or are here, and how I think your best interest would be to think through some of the emerging technologies that we all are going to need. And then last but not least, I'll finish up with our strategy in implementing our network care and our coordinated care and some of the high priorities that we have. I hope that'll hit the mark for you today, and then hopefully save some time for questions. So this slide illustrates what I call the Stanford operating rhythm. Every year, every quarter, every month, we revisit this slide. And this slide was created by our new CEO who came on board a couple years ago from UCLA. And I recall him telling me that when he announced his departure at UCLA and the fact that Stanford's building a new hospital, a colleague came up to him and said, "Wow, you're going to have to do a new hospital again. And Amir said, yeah, but you've got to do EPIC. Because we finished EPIC in 2009. So our mission, our vision, values play heavily in all that we do, but we have two strategies around leading edge and coordinated care. So we have a network strategy, and I'm sure some of you have the same strategy in your market. And then we have a complex care because we are an academic medical center, and tertiary care is very important to us, but we also recognize alliances in the community. Alliances with other providers are just as important for our growth in this new market. And we're heavily in lean. Process improvement and performance is measured on our ability to drive change and drive toward our metrics. We all have dashboards in place today, and those dashboards are used in our monthly and quarterly and senior leadership meetings to measure how well we're moving forward and whether or not we're achieving the outcomes that we have all signed up for. So this chart illustrates the journey that we believe will differentiate Stanford from our competitors. Discovery. We have very distinguished scientists and physicians who have received Nobel Prizes, 2 recently. And we also have a deep and very well-known research entity within an academic medical center. Translation through discovering and multidisciplinary care all the way through access. We're working on expanding access to our services in the coordinated care area. And last but not least, lifetime partners. In managing a population, managing a patient's life is key to our survival in our market. We can no longer accept very sick patients, take care of those patients, send them home well. In today's market, in today's global changes that are occurring not only nationally but internationally, it is the lifetime partnership that we think is where we can differentiate Stanford. And through leading care and coordinated care beyond the boundaries of the physical plant called Stanford Hospital Clinics will be extremely important to the survival of Stanford. So in the last couple of years, we have embarked on creating a medical foundation, and this is really our vehicle for aligning the community physicians and aligning IPAs with Stanford. We are acquiring IPAs, physician groups, just like many of you, and we are focusing on primary and secondary care. And I've been at Stanford now almost 11 years, and tertiary acute care has been our primary vehicle for giving care to the community. And now we know we have to branch out to the community and branch out beyond the walls of Stanford in order to financially survive. And last but not least, we think leading care and coordinated care and our UHA Medical Foundation and the relationships and the acquisitions we're making will position us for multiple scenarios around accountable care organizations. This is just a picture showing you where we have branched out. We're in a very competitive market. Make no mistake about it. I'm sure there's very competitive markets in Southern California. But we recognized 3-4 years ago that we needed to build a broader network in our market. And you can see the locations that we're now either owning physicians or affiliating and purchasing IPAs. We're also reaching out and providing to a number of other organizations very specialized care, which is our specialty. So we have placed physicians and we have placed staff in other organizations throughout our market, which is another strategy that we have in order to determine the right accountable care scenarios for Stanford. So I would say in the last 5 years, we have been looking externally. The first 5 years that I was at Stanford, it was very much looking internally. And I don't see this changing in the next 10 years and beyond. I would be remiss if I didn't talk about the Stage 7 award that we received in 2009. John was part of the survey team that came to Stanford, and we were quite pleased with that award. We had just finished our 3-year, 9-month EMR project, which came in on time and on budget, and was very successful. We have a high adoption rate. There's not much that we didn't go live with in that period of time that came from our vendor, Epic. So very happy about that. And over the last really 2-3 years, we have been recognized as one of the most wired, and also recognized by U.S. News to being one of the best hospitals for information technology. So needed to share that with everybody. So now I want to shift. Now I want to try and talk about strategies for the 21st century and what the next generation care delivery is looking like, at least from Stanford's view and from my view. Okay? I think there are certain changes in our industry that are going to lead us to changes in our technology solutions and changes in our thinking about what we need to do to support each of our organizations. There's no doubt in my mind that we're shifting to a very value-driven model in the future. Pay for performance is here and it will stay. So fee for results and outcomes and quality will be prevalent, more prevalent than today. Our providers will no longer be individual providers. I think that they will be paid based on a patient annual visit versus an incident or a visit. And I also think that we will be able to pay, and in some states we can today, providers can be paid for a virtual visit or a home visit. Providers will be paid as part of a team. Think about it as we move into an accountable care structures and scenarios. It's not just a single visit or a single diagnosis. It is a diagnosis or a patient journey or a patient care over a longer period of time. So I believe providers will be recognized as part of a care team, and they will be paid as part of a care team. Quality must be, B. I forgot the E. But thank goodness B is B. And bonuses will be based on achieving identified targets from a quality perspective. And last but not least, I think there will be high incentives both from the government and both from our payors to be able to prevent care and prevent illness and move into more of a wellness state of mind. So I think these are some of the changes we're all faced with today, and it's going to be really more prevalent in the next 5 to 10 years. So when you look at global trends, certainly here in the U.S., but also internationally, there are, in my opinion, 4 changes that are occurring, at least from my research. Complexity. I think John talked about that this morning, how complex our environments and our organizations are becoming. Complex data types, complex information streams. Think about it. Following a patient that leaves your organization is visited by another organization, and tracking that care and tracking that payment stream under healthcare reform. Revolutions in genomics will turn this inside and out, in my opinion, and incorporating genomics into the clinical care process within your hospital setting or in your organization setting is quite complex, will be complex. Coordination. Coordination leads me to think about a couple things. One, the transition to a team-based models of care, multidisciplinary teams of people taking care of a patient, being paid based on a multidisciplinary team model, and having to really accommodate the information and the workflow requirements of many stakeholders and many organizations will be absolutely key for most of us in the next decade. Coordinating that care beyond your walls, beyond your organization, beyond your IT environment. Certainly collective payment or collective responsibility is part of healthcare reform. That will change the way reimbursement occurs. There will be new alternative payment schemes that will become more prevalent. Think about it, all of the work we've done in our revenue cycles over the last 20 to 30 years. Think about the changes that might occur there. And then last but not least, sharing the end-to-end responsibility and collecting that health and data information. We've been talking about electronic patient records for a long time. The next decade, I believe, it will be critical that we can achieve an electronic medical health record and follow that patient in every organization that might take care of that patient in his or her time, and be measured by the quality of the results. I'm sure each organization that's representative here has a very strong, robust quality department, CMOs who work day in and day out to ensure that the highest quality is being given. Think about ensuring that the highest quality not only in your organization is occurring, but in other organizations. And then last but not least, we're all seeing this happen, moving toward a community-based model of care. This is a important change because wellness and aging in place is all part of our new culture and new responsibility. Care, we've been planning for healthcare reform for about 5 years at Stanford. We've been very fortunate to be able to manage through the ups and downs of the last 5 years, but we haven't seen the drive for cost-effective care based on truly quality outcomes, and I think that's going to happen in the next 5 years. The care capacity is moving beyond the walls of a hospital or beyond the walls of the clinics that are associated. Building out technology and building out services that happen in the home, whether it's remote monitoring, whether it's conducting blood analysis, whatever it is, it's moving out into the community. And last but not least, when this is happening and the more geographically we become as organizations, we're going to have the tools, the mobile tools, to allow us to collect this information, to allow us to analyze the information for many, many purposes. So there are the four, I think, important global trends that we're all faced with and all need to be thinking about as we plan for the next generation of technology. So now I want to take a few minutes and talk about the enabling technologies that we may all have in place today, maybe not all, but some, but we should be thinking about many of these now and certainly in the future. From a connectivity perspective, coordinated care, again, one of our strategies is coordinated care across our organization, across our University Health Alliance, across affiliated IPAs, and even across providers. Coordinated care requires really a change in culture, rewards, even our infrastructure, and relationships between patients and clinicians and staff and family. And these are the ways in which we're preparing at Stanford, and these are probably many of the ways that you're preparing in your organization. Electronic health record is absolutely critical to achieve meaningful use. All of us are working on meaningful use and being certified by CMS and the Office of the National Coordinator. Many organizations are in the midst of implementing their electronic health records. Many organizations are in the process of selecting the one that will meet their organizations for the future. Health information exchanges, if you haven't put your strategy in place and you haven't selected the solution that you believe will work for your organization, I would start doing that now because to be able to transact care within your organization and outside your organization, across organizational boundaries, you will need this technology. Our infrastructure, security, secure, high availability networks will be prevalent within the community, within your organization. Changes will have to be made in order to support a more diverse geographically organization. Collaborating with other organizations on your strategies for infrastructure and networking will be required. And then last but not least, scalable energy, efficient infrastructure, client devices, robust end-to-end security must be managed remotely across and within your organization. The second enabling technology is coordination. And John talked about this as well, and I've mentioned it a couple of times. The new care delivery models that we're all working on and thinking about and strategizing about for the next 5 to 10 years will really require a level of care coordination across our organizations that we've not seen previously. Quality outcomes will be required, and new processes will need to be developed in order to be able to do that. So at Stanford, we've embraced online portals. These portals are mostly designed for within our organization, and I would argue to say that for us, we will have to find a way to extend and offer our online portals across other organizations. Authentication tools to safeguard patient confidentiality. I don't know about you, but I know at Stanford in the last 10 years, I would probably say we've spent close to $30 million on tools for security and the privacy of PHI. Real-time dashboards, real-time quality dashboards that can monitor the patient's outcomes. Teleconferencing capabilities. I'll talk in a minute about our strategy with employers in our market and how we're extending clinics in several of the Silicon Valley companies that are in our market, and even, I believe, one that's in your market, which is kind of cool. And last but not least, tracking and having the audit capabilities to monitor the quality of delivered care, certainly within our own organization, and when we begin to exchange information in an accountable care structure, it will be important for us to be able to collect each other's data in order to measure and monitor. Decision support, it never goes away. I believe that there will be an increasing need. I think a couple years ago I talked about the BI analytics program that we put in place at Stanford. Analytics will be key to improving processes. We will have to collect and standardize terminology in real time. I mean, we've talked about this for a long time in the industry, but we will have to do that. Portals will have to help our consumers navigate much better than they have today and provide more education. And then last but not least, clinical analytics. When it moves from analytics to predictive analytics, which it will, there are many organizations and even several companies who are working on predictive analytics, will change the way we give care almost in real time. Community, home, and individual. In order to sustain the cost savings and the reduction in costs that we will all be faced with very shortly, if not now, we will need to move to the home. It's just as simple as it can be in today's world, and to the community. And we will have to figure out how to, from a care perspective, and then enabling from a technology perspective, how we can take care of our patients in the community and in the home, or in a ambulatory setting such as a ambulatory ICU. We opened we call it the Stanford Coordinated Care. We opened a new clinic about beginning of the year where it is an ambulatory ICU where critical patients can be taken care of in an ambulatory setting. Remote monitoring, telehealth, all of you probably have strategies around this and implementations going on. Virtual visits to minimize the need to bring patients into the clinic or the hospital. We're doing this today with several organizations. And certainly secure and high speed, our infrastructure has to be very robust, both the infrastructure we have today, but also the wireless infrastructure for us to become more mobile outside the boundaries of our wall is critical. And then just a few more. Health solutions for behavioral health, again, managing a patient population, but managing a patient for the lifetime of that patient will require us to engage in very different services at Stanford, and we believe that having the mobile devices and coaching and reminders, collecting data, and performing other functions will be critical for us to achieve from a strategy perspective, but to develop the environment and the tools in order to enable those services. And again, analytical software is truly one of the top priorities at Stanford. And I would suspect that if you read any of the healthcare technology magazines or blogs, analytics seems to be the theme across our industry for the next generation. So there's just some thoughts that I think I know at Stanford over the last 3-4 years we thought a lot about, and we have some strategies in place where we think will differentiate us from the market. Virtualizing our services is probably next to building a new hospital. Virtualizing our services in a way that we don't provide services today is probably the second top priority we have. And I'll show you some examples of what we're talking about today. So when we look at Stanford and we try to think about the change in the care delivery model. I mean, Stanford has been an academic medical center. You're very sick, you get seen in one of our specialty clinics. You may go immediately into the hospital. We take care of you, and we're very proud that if you come to Stanford, we believe you have the best chance to walk out of Stanford. But we are thinking that there's a new model, and that new model has concepts that will differentiate us. And let me try to explain it. A membership. We believe that we can offer to our patients a membership to be a health partner with Stanford beyond what we do today. Okay. Knowing who they are is high on our priority. How many times do you see a doctor where they want you to fill out a form and they want to know why you're there and what's wrong with you? So knowing you, knowing your complete health condition, your complete health being, knowing your family, knowing how many kids you have, knowing who is your life partner, what do you do in your spare time. Knowing all of that about you is part of our strategy. And then gathering, then understanding that, knowing what to do through a multidisciplinary team approach, which is not unique, by the way. I mean, I worked at Mayo. Multidisciplinary team care has been the care model for Mayo from the very beginning. But at Stanford, it hasn't been that model. So knowing what to do and knowing who needs to be part of that is a concept that we're working hard on. Doing it, just taking action and doing it. And then in the back stage, obviously, the doc-to-doc relationship is very important. And this is not doc-to-doc within Stanford's organization necessarily. It's doc-to-doc within the community, doc-to-doc within the provider organizations. So these concepts, we've spent a lot of time thinking through what would be the vision and how would that look. And I was going to bring a video today because we created a video that actually describes this slide, which we showed to the board in September. And it's pretty unique, but my boss, the CEO, is very protective of that slide, that video. And he has asked me not to share the video because the video is quite unique, and it's very visionary, and it's really the vision for what we're going to look like in the next 5 to 10 years. But that said, I'll try to describe it in a couple other ways. So we use Epic, and we use Epic to connect Stanford to each other, but we also use Epic to communicate with others in our market. Okay, we have about 9,000 referring physicians in California and beyond, and we use Epic affiliate link. We call it Prism. We use Epic for our faculty. We have about 1,000 plus physicians who are using Epic. In our IPA, we have about 893 affiliated IPAs. Referring physicians. And then, of course, in the UHA, this number has changed. It's about 250 docs now that have joined our medical foundation in our market. And from the very beginning when we did Epic, we felt that the tools within Epic would help us do a couple things in our market. And I'll talk about just one. It's called stickiness. And we're giving Epic, by the way, we're subsidizing Epic in our market. And stickiness is, wow, you give them so much features and functions. You give them good service. You give them good quality at a cost. And you provide all the information that you can collect. That's stickiness. They have to come back. We want them to come back. So stickiness is very important in building out our network of care, but also continuing to build on our coordinated care strategy as well. And then what we've been doing, we have realized some people might say, what took you so long? But we realized, wow, we're in Silicon Valley. And there's a long list of very creative and very innovative companies that we should be talking with and working with. And we're doing it in a couple of ways. We created a program called Corporate Partners. And we have gone out to many of the large technology companies, large companies in Silicon Valley, and offered them to be a corporate partner of Stanford. And a corporate partner in a way in which they have signed up to give us millions of dollars for the next 7 years for us to use, primarily for building the most innovative, advanced academic medical center you can, because we're building a new hospital that will open up in 2018. And then there's a portion of what they give us that is dedicated to innovation. Innovation in technology, innovation in medical care, innovation in science, innovation. So, and we're nurturing that. We spend, my team and myself, we spend every quarter rotating visits with Intel and Cisco and Facebook and Google, Intuit, Oracle, I mean all of them. And we actually we actually meet with the people in charge of innovation. It's not the salespeople, it's not the product developers even. It's the individuals who are thinking beyond the current product available today and even beyond the next 3 or 4 products that they're putting out. So we're doing that, and which is quite exciting. And there's a number of things that we've been working on with some of them. The other thing we're doing is we're offering to open a clinic, a Stanford-owned, managed clinic. And of course, our EMR will be used within that clinic. At Cisco, you can go and see a dermatology clinic and a dermatologist actually from Stanford who sees employees' families right on campus. And we'll be opening more in other campuses, but right now there's one in San Jose. Qualcomm. Last week on Friday, we came down and spoke about the same similar arrangement, opening a Stanford clinic. And sometimes it's a family practice, sometimes it's internal medicine, sometimes it's dermatology. And we use technology, we use Cisco's telepresence technology to be able to have our dermatologists talk to the dermatologist or the nurse when they're seeing a patient. It's pretty cool. So we, this is another slide. It might be a little redundant, but we believe engaging our customers through technology will greatly enhance the relationships with our patient. And you will see more of that from Stanford in very innovative ways in the next 5 years. And we're quite pleased with how many patients now actually interact with us through these means. My chart, or My Health, that's what we call our patient chart. We're seeing this as a means for even non-patients to join our partnership and be a member in our Stanford Health Partners program. We opened in Shanghai and China this year, and Hong Kong, affiliated with both universities in those countries. Research, education, CME type things from Stanford are being done in those countries. And we're using our EMR, our My Health, and we're using telepresence technology to do that. This is another example of what we're talking about in terms of building some unique offerings. Tumor board will be implemented later this year, but in order to do the things that we want to do to connect not only our organization in a very diverse way, but to connect our patients and to connect other doctors are key to what we're trying to do. So if I pulled everything together, it would look like this slide, and I'll just briefly talk about it. We're creating a new Stanford network. That new Stanford network is really focused around the patient, and it's focused around creating a culture and a program in which patients feel like they have a partnership with us, regardless of what their needs are, regardless of whether or not they even need to see a doctor. And we're going to do that through what we're calling the Stanford Health Cloud. Now, this term cloud has absolutely nothing to do with cloud technology. Our new CEO likes it. And we're using it. But it is virtual services. It is e-visits. It is virtualizing and mobilizing all of the services we provide, both from a clinical perspective, educational perspective, and any other perspective we can think of. It's virtualizing our services. Again, moving things to the community, moving things to the home, and moving services off the main campus. And then hospital relationships, where we've entertained many conversations in the last 2 or 3 years around purchase, merge, build, buy, and we will continue to do so to build out our ACO scenarios that we think are worth our time and effort at Stanford. And then IPAs, lots of work being done there, University Health Alliance, the Affinity IPA, and that's growing substantially. And we're giving them Epic, we're subsidizing Epic to do that. And then faculty, we're doing many things with the faculty. So when you look at how we're changing our network, because we were very campus-based, very acute-based, we're becoming a health system, and we're positioning ourselves in the market, hopefully to differentiate Stanford from our competitors. This just summarizes what I talked about, differentiation through leading edge and coordinated care. There is an economic advantage for us to do this in our market and beyond our market. In complex care, we're really developing our service lines strategically, because it's important that we can continue to provide the acute tertiary care that we've been known to provide. Specialty care outreach, I talked about that. We've got neurology, neurosurgery, we've got transplant in other organizations provided by Stanford. The network of care, boy, that's a big focus for us. That's where we're seeing mobile and virtual services, analytics across our boundaries needing to be developed. And then last but not least, performance management improvement. We're knee-deep into lean, and another strategy is CI Care, which is our patient satisfaction. We've made significant strides in improving our service, which we all know is key to keeping our patients. So that's kind of hopefully a little insight into what we've been thinking about, how we've positioned Stanford in a changing market, and a changing global market, if you will, for healthcare delivery. Now, how much time do I have? Can I take a few more minutes? Oh, 5. Okay. Very quickly, we are building a new hospital It'll open, believe it or not, it'll open in 2018. It's not that far away. We've been working on the, what I call the environmental and infrastructure necessary before we can break ground, and we'll break ground in March. But the way we're approaching it, there's planning, collaboration, and innovation, and I'll talk briefly, very briefly, about our innovation program that we've developed in support of our corporate partners and in the hospital. This is a busy slide. There's really nothing to say about this, but all of you think about this day in and day out because there's technologies in order to make this the most advanced digital environment. We're looking at a lot of them. We've gone through this year in researching, and in fiscal year 13, we have to start to figure out how do we bring it all together, and then who are the organizations, the vendors who are going to help us build this. But it's a little busy slide, and I apologize for that. But we're looking at a digital care. I mean, all of you have built hospitals probably, and that's your goal as well. And we're looking at real-time healthcare in very different ways than we do today. So quickly about innovation. Innovation isn't necessarily a culture. In my mind, innovation is a process, structure. It's a mechanism to gather new, innovative thinking. It's a mechanism to look at those organizations that have innovative technologies. And it's a way in which organizations can position them to make the best decisions that they possibly can around innovation. Without process and without structure, innovation just doesn't happen. You have to have a way in which you can collect it, evaluate it, test it, agree to it, purchase, build, buy. It's a process. And this is the process that we put in place. Actually, I have to be honest with you. This is a process that we put in place back in 2004 when we decided to outsource IT. And I had this great idea that we were going to be the most innovative management team because we outsourced. The day-to-day is going to be managed by somebody else. And we went off-site, built this model with some help from Cisco, and it lasted about a year. And it lasted about a year because we were not disciplined enough to understand that it is a process. And the process has to be managed, and the process has to be visible to everybody, not only the people in IT. And last but not least, it needs funding. Very simple reasons why things don't work. So about 2 years ago, when we were thinking of the new hospital, we said, let's give this another shot. So we wiped it off a little bit, pulled it together, and this is what we did. And I'll explain the sense, generate, select, develop, and execute. But it's a model where ideas come forward, sometimes from our corporate partners, sometimes from new solutions, sometimes through doctors or any individual in the organization. And we have an innovation council made up of small, not large, 10 people. 10 individuals in the organization that are interested in it and want to look at new technology with us and look at new ideas. So 10 people. And we bring ideas. Sometimes it's the school that brings ideas to us. Sometimes it's maybe Lucille Packard Children's Hospital. Not often. They usually keep their good ideas. We do too. And sometimes it's the doctor. I got an idea. And it comes forward, and my team tries to pull as much data as we can about the idea. And it comes to the council, and if the council says, wow, this is a cool idea, can we do this? And then if the council says we should do this, then we put it in our test lab. And then we may prototype it. We have a couple of prototypes going on right now. And if it really passes the test where our stakeholders are involved in using it and checking it out and validating it, then we're going to put it in our showcase. And our showcase will be, quote, the new hospital is going to look like. So that's our innovation program. So a couple thoughts about the methodology, because it is a process. It's not a free forum. Anybody has an idea, gee, let's do this. It's not. It's a process. And on the right, you can see some of the activities. Sensing is really becoming aware of the trends. So there's a lot of research involved in it, and people want to understand that. Generating is you bring it in, you present it, you understand it, you get people to advocate that we should try this. And then you have to have a forum for selecting it, and that's what our Innovation Council is. Is this a good idea? Is this one we want to spend time on? Is this one we want to spend money on? And then if we do, then we develop it. We may prototype it. We may build it ourselves. That's something new at Stanford, believe it or not, at least in the hospital setting. And then last but not least, if it proves out, then let's execute it. Let's carry it out. Let's do it. So each one of these steps is a process and a methodology in which we use to decide what new innovative ideas will go into the new hospital. This last slide, everybody has a slide like this. I've been using this slide for about 4 years. And every year, at the bottom of the slide is the new hospital, things we're doing in order to open a brand new hospital. On top of the slide are some of the other things we're doing. Health information exchange this year, analytics, heavy involvement in analytics, the Stanford Health Cloud, virtualizing our services, e-visit, e-consult, e-telehealth, big. And then a few other odds and ends. We're going to replace lab and pathology. We're going to replace about 10 freestanding systems with Epic in fiscal year 13. Everything that we're doing, I believe at some point in time, we need to shut down a good bit of the other stuff we're doing and really refocus and resource and mobilize everybody around the new hospital. And I think that will start to be in fiscal year 14 and 15. Thank you. John.
Just a question on a question on your connectedness. I can't remember what it was called, but the patients or partner, the health partner for life, or whatever you called it.
There's two things. There's a Stanford Health Partnership, which is kind of a membership in being able to access all of our services, whether you're a patient or not. And then the other was corporate partners. This is the employer.
Yeah, on the first one. So Epic as a great integrator for the clinical information. I'm wondering if you have thought about, or as the group talked about, CRM in healthcare. You know, it became a topic maybe 8-10 years ago. I haven't seen it really take off. But when you mentioned, you know, who's your significant other, how many kids do you have, when their birthday, the sort of really connectedness, which, you know, the vendors in the room have all of us in their CRM, and who we like and who we don't like. Is it a time, do you think, that with healthcare and I mean, Epic doesn't do that. Do you think there'll be a CRM in health?
Absolutely. A couple years ago, we looked at the market, and we actually came very close to engaging with a leading CRM vendor, and we backed off. And not because we don't think we need CRM. We're in the process of going through consolidation of our call centers. We have probably 14 or 15 call centers. And we backed off of buying another product. And we're going to use the Epic product initially, because CRM must be so integrated into your electronic medical record that trying to integrate a CRM system into Epic wasn't something we felt we could take on at this particular time. But it is. Matter of fact, we've shifted from purchasing a product to looking at the workflow first and consolidating our call centers and other services that are decentralized right now. If we can do that and redesign it, then CRM is a given. We're already funded for it. It was on our list, but we just said, let's do the process improvement first. Let's figure out how we're going to use it.
Thanks. Carolyn, over here.
Oh, hi, Joe.
Hi. So you've had many crucial conversations with your leadership team about different topics, budgets, performance, insourcing, outsourcing. And this morning we heard from the CEO that it's all about the gut. Do you have any reactions to that, and can you impart any wisdom from your career on that?
I do have a reaction to that, and I couldn't agree with him more. A couple of things that stood out for me because I've been, well, I won't go down that path. But anyways, a couple of things stood out for me was, the farther up the leadership chain, to be a good leader, you cannot manage day to day, and you shouldn't. You have to lead, and leading is making decisions and making right ones sometimes and making wrong ones some other times. But the farther up the ladder you go, you must lead, and you have to be willing to accept the fact that you're not as close as you used to be, and you may not know all that you used to be. I mean, I'm always surprised at how much is going on in my department that I don't know about. So that's one thing. Second, I totally agree that at the board level, it is about confidence and trust. And I've experienced that myself with our board. He's right, you get maybe 30 minutes. We have a board IT committee that meets the day before the full board, and we get an hour. Now, there were a couple of really important changes that our CEO made at the time, the CEO that hired me back in 2002. And that was a concept, and our CFO had this concept. I believe in this concept. I believe in it. You only go to the bank once. And what I mean by that, a lot of the organizations, and I'll give you, I know a lot of organizations may not have the cash. But when you're doing an EMR project, and you think about, well, we may not be able to afford this or this or this, let's break it down, let's just take this piece, let's just do the hospital. And you say, I'll come back. We have not done that at Stanford. We go to the bank once, absolutely once. Epic across the board. Everything Epic sold, with the exception of lab and radiology, we put in 3.5 years. And we went to the bank once. And we do that consistently. So that's one advantage that we have at Stanford. The other thing I think that's very important is that I can think of a couple of situations that if I had not had the confidence and credibility at the board level, I might be working for a different organization, because you can't do everything right all the time. We've had some challenges. But because of that, I believe we've weathered through them, and we were very successful. And so I really associated with John's comments this morning a lot, and I have some individuals who are in associate CIO positions right now. I wish they were here to see and hear what he had to say. But leadership is tough, and it is judgment. I often look at people that I'm hiring, and sometimes I'm too quick to say that's the person. But what I usually look at, do they have good judgment? Do they have good judgment? And can I trust them? And are they smarter than I am? That usually works.
I have a question. With the build out, I'm over here. With the build out of your care network, UHA, et cetera, how has this changed your transfer center operation? What challenges have been uncovered? Are you building out a dashboard that integrates all of the information they need from all the different systems so that they can adequately support and respond to referring physicians, that type of thing?
Right. The answer to that is all yes. We're doing a lot of work to make that work because it does become more complex. Stanford, we have a huge challenge with UHA right now because we've been so successful in buying these practices in Northern California. The infrastructure isn't quite there. And when I talk about infrastructure, it's not IT infrastructure. That's not there. We have to put it in place. But even the infrastructure for things like that, we're trying to figure out and how to improve on. Infrastructure on how we do onboarding. Every practice is different. Every deal is different. Just getting consistent quality practices across all these physician groups, education. We're now, I call it the remediation stage. Even though we have close to 300 docs that we now have as part of our University Health Alliance, we're knee-deep in figuring out how do we make them act and feel like a system. And from an IT, there's an associate CIO who's just been recently assigned to UHA, and we're finishing up on our strategy to make them part of us. Because, you know, we've got all these sites out there, and you'd be surprised how many lab systems we found, how many managed care systems, how many email systems, how many billing systems. So we've got them, now we have them, and now we have to put the technology to make them feel like part of us and make them feel like a system. So we're just dealing with all those issues. Yes, we should.
One last question.
I have a question. Over here to your right.
Yes.
So the question I have is, you spoke about your corporate partners. In particular, I'm thinking about Cisco. Cisco is very, very active in their community. They have their own clinics. They have their own total population health management approach. And there's a number of other major employers up in the Northern California area that have this. What is your strategy from a technology perspective of integrating these total population health management approaches between what you're bringing to the community and what's been established by many of these employers today?
Well, our strategy is primarily providing the specialty care, because most of what the employers are doing from a company-based clinic, if you will, is primary care. Because you take Cisco, you take Google, you take all these companies, the average age is what, 32, 33, something like that. So they're primary care focused. So our strategy is specialty focused, such as the dermatology clinic. Have we talked with other organizations about providing the primary care? We have, but there are a number of companies, small niche companies, who have sprouted up, and they have docs, and they have an EMR, maybe not as robust as ours, but they can do primary care pretty quick. And Cisco went with a company just like that for their primary care, global primary care clinic on site. So our strategy has been specialty care first. If we can get in and compete, and we have competed, but we didn't get some of the global primary care service contracts, but we haven't walked away from it. But it's hard to compete. We're large, complex. We move fast when we need to, but we also move slow. But it's been in the specialty care area first. Thank you. Catch you later. Thank you.
So we have a lunch break, and I want to thank our speakers this morning again. Tom did have to leave, so unfortunately he won't be able to stay. Carolyn does have a flight to catch later, so she won't be on the panel. So if you want to talk to her and you have additional questions, try to catch her during the breaks. We're going to get back on track and meet back at 12:45 for John's speech. All right? Thanks.